Good evening, everyone. Can you hear us okay? If someone just give me a thumbs up if they can hear us okay, that would be great.
You guys, can you come here and get the background out? Like, I think they can see photos of me. And no, just do something about it. I don't know how to do that.
Thank you, Karen. Thank you for confirming that you can hear us. Always like to check and start talking and no one can hear. So welcome everybody to the webinar this evening. Thank you very much for joining us. We're going to kick off. Emily is running a little bit late, but she'll be here shortly. So I just would like to introduce Katina from Wellbeing SA, who is going to give us the presentation on vaccine hesitancy. And we also have Melanie Smith with us as well, GP Liaison Officer with SA Health, and Emily, who will be joining us shortly. I might now hand over to Katina to start the presentation. Can you all see the presentation that's on the screen?
Just move it to the presentation. I can do that.
Thank you, Amanda.
Hi, everybody. So I'm going to be talking about vaccine hesitancy and the work that we're doing in South Australia. And thank you for joining me today. We'll have questions at the end. This goes for around about an hour. Okay, so first I'll talk quickly about the role of the vaccine in COVID control, the common questions that we're getting, and I'm sure you guys can help us with other questions that you might be getting in the community, and then talk through the evidence-based style of communication that's the most effective. So I think it's important just to acknowledge right off the bat that obviously the vaccine is important, but it's not in itself going to be sufficient, that we do need to keep doing the things like the COVID safe check-in, which helps rapid contact tracing, all the respiratory hygiene practices, and checking restrictions before hosting an activity or gathering. All of those things we must imagine are still going to be in place for some time. So just to start it off, I guess what we're really talking about here is the Delta variant, which has clearly completely taken over. You might well already be aware, but what we now know is that the Delta variant is at least twice as infectious as the original Wuhan strain. So the reproductive number sits more at around 5 to 8. So that's every case of infection passing it on to between 5 and 8 people on average, compared to the Wuhan variant, which was more like 3. So there's also good evidence now that we have greater severity with this variant. So everything I'm talking about now relates to this. This is a slide on straight out of the Doherty report. I don't know if any of you have had a chance to read it, but I think it's quite helpful because it really just talks to the role of vaccines in COVID control. So if you look on the far right is the transmission potential. So 8 being where the Delta variant would be, so that's a reproductive number of 8. If we had no controls whatsoever in a completely non-immune population. And what we're obviously trying to do is bring that down to less than 1, which means we have a dying number. The modelling basically still has that we should, in this kind of peachy colour, we should still have our optimal test, trace, isolation and quarantine. So that means people are still getting tested and we still do rapid and effective contact tracing. In addition to other public health and social measures. So that might be things like the density measures and, obviously the respiratory hygiene and those sorts of things that we've already talked about. So the idea is that an 80% vaccination coverage will contribute this additional reduction in transmission potential to bring us closer to 1. As you can see, as we get, we will still need to potentially do some more additional control measures at 80% coverage. But what we hopefully won't need to do is what this dark green bar represents, which is lockdown. So effectively, this is really what we're trying to achieve, but really important to note that it's vaccination coverage plus high quality, effective test, trace, isolation and quarantine. And Emily, hi, do you want to say hi?
Oh, good evening to everyone. Apologies, I was a little bit late, caught in traffic, but thank you, Katina, for taking us through this journey around hesitancy. Looking forward to it.
Okay, so this is really may well be well known to everybody, but I just feel like it's important to kind of cover all the basics so that we are all across the same sort of information. The Pfizer could be Pfizer/Moderna, they basically perform the same, but really where these vaccines excel is in the reduction of hospitalisation, ICU admission and death, and for reduction of death is 90% or higher. And so when we're talking to people about hesitancy, it's really important to be clear about the absolute high benefits from the vaccine, which is really about severity of illness. The other thing to note is that there is reduction in infection. AstraZeneca's around that 60% mark, Moderna and Pfizer around 80%. But even if a person is infected, which is of course less likely, the risk of transmitting the infection onto others is half what it would be if you were a non-vaccinated person who was infected. So we have these kind of knock-on effects, reduced risk of infection, reduced risk of transmission, and reduced risk of serious illness and death. And I think when talking to people about it, sometimes all of that is really important to talk about. I'm going to go over these ones quickly because everybody knows we've got above 12 and above for Pfizer and Moderna, and for AstraZeneca 60 plus. And we also all probably know that the uptake of AstraZeneca now is really dying right off and it's being replaced by Pfizer and Moderna. I will share these slides after so everyone can, because some of these slides are actually, I think, quite helpful when talking to people. So one of the things that is really difficult, I've come to realise that when we talk about vaccines, we usually talk in the abstract. We talk like scientists, we don't realise we're doing it. To even say an 80% reduction is not a meaningful thing to many people in the community. And so we've got this, and we're actually going to develop more slides which will help us more with community conversations. But this one's taken from the WHO, and it really just tries to look at what vaccine efficacy means, but you could replace this with hospitalisation or what have you. The difference in infections between the vaccinated and unvaccinated. So if we have, for example, 10 people who are infected in the unvaccinated group and only 2 in the vaccinated group, that is 80% reduction. And I realise that everybody here knows that, but I think there's some real value in getting completely concrete when talking to some people in the community about what this all means. So I'm reluctant to discuss all of this with you guys because I'm sure you all completely know about this, but I wonder if this is really just the sort of thing I go through when talking to people about especially the mRNA. And we've been trying to work out how we say this in a way for some communities who completely have no health literacy whatsoever. And what we've really been talking about is that the mRNA brings instructions or a recipe book into our body that helps our cells to make the protein or the spike protein, and so that our immune system can mount a response. That's the kind of the simplest we can come up with. And then we've kind of talked about as well, going forward, that we create an immune response that our body remembers. And we have kind of, you know, one Aboriginal staff member put it to me as security guards, effectively going through the body, waiting to identify the COVID virus coming in, to then bring on the army and attack it. So some way of kind of explaining that what we have is memory cells that give us immunity in the long run, which can also help with talking about boosting, should that become something that we do for everybody, that it's about helping us to remember what the virus looks like so we can kill it. We're tending not to talk to people so much about the AstraZeneca anymore. The other thing that sometimes people, obviously vaccine safety is a really critical part of people's concerns. Sometimes it's important to talk people through the role of the Therapeutic Goods Administration versus the role of a TARDI, because they just get used in the media kind of interchangeably or seemingly. But just to be clear, that TGA obviously licenses drugs and other medical devices. A TARDI tells us how we can use it. And so one of the things we talk about with people is that this system has been in place for very many years. It's the exact same system that has been used for approval of the vaccines, and that there's been no shortcuts taken. They've done exactly the same as they've always done.
Can I ask a question while we're going? I mean, but something that we often get asked about is the provisional approval process around the TGA, and noting what that means from a vaccine point of view, and what that means for patients who've done their own research and understanding what that means. I don't know if you're happy to step through that at all, Katina.
Well, I'm certainly no expert, but I do actually have information on that, because it's one of those things that I wanted to know.
Yes.
What does provisional mean? It doesn't sound very good.
No.
But basically, my understanding of it is that it allows the TGA to continue to closely monitor over time, so that we can be precisely sure that we don't have any kind of untoward effects that haven't become apparent in the original approval process, such that at some future time it will get full approval. Is that also what you can understand?
Yes. I remember saying, and I think the other thing as well is around how many years it can stay provisionally approved for. It's a 2-year period, and then it can be extended up to, I think, 6 years. And that may be the case. We might end up, but we might then move to 4.
Yeah, I mean, I guess we would think, because of the number of people getting these drugs, that it should, you would have hoped it would be faster than slower, but it'll just depend. Thank you. So obviously there's the common side effects. It is important when talking about this with people that we are completely transparent. Obviously that's part of general consent process. But the real thing that people want to talk about is a serious and rare side effects. We'll just wait till we get a laugh. Thank you. So for Pfizer and Moderna, they basically have similar side effects. So it's really, most importantly, I mean, there's anaphylaxis, which is obviously something that can happen. But my understanding is we haven't had anyone die or have serious consequences of that anaphylaxis within Australia, because it's treated on the spot. So that's, I guess, not so much of a concern. The issue of myocarditis, pericarditis, is perhaps the most common of the serious side effects. The general population rate is 2.7 per 100,000. This compares with, if you've got COVID infection, of 11 per 100,000 people getting myocarditis or pericarditis. People do need to have a specialist review, generally cardiology review, and may need to be admitted for this. But again, we haven't had anyone with any very serious myocarditis or pericarditis. Everybody has completely resolved with no ongoing cardiac deficiency. So it's one of those things that we should talk about, but it is generally mild, has always been treatable to date. The group of people who are most at risk are men under the age of 30. They have quite a substantially higher risk of this, and it's usually after the second dose and between 1 to 5 days after vaccination. So people present with the usual chest pain, shortness of breath, arrhythmia, syncope. In terms of the thrombosis with thrombocytopenia syndrome, This is around 1 in 50,000 now, is where we think we're up to. But the risk of dying has substantially reduced since when it was first apparent, to now being 1 in 1 million. Obviously, that's, we don't want anybody dying from a vaccine. I think that's probably fair to say, but it is a diminishingly small now. And I guess the comparison really, and this is more for people who, for example, can't be given a Pfizer, perhaps they're allergic to one of the components, or perhaps they've had myocarditis in the last 6 months and the cardiologists would prefer AstraZeneca, so because some people will recommend a delay. But the risk of death from COVID is 1%, which is 10,000 in a million. So that's really the comparison, 1 in a million to 10,000 in a million. So I guess these things all depend on a person's individual risk-benefit profile. Okay, there are some contraindications as well for the AstraZeneca, which I'm sure you will know about. But basically, there's specific types of clotting syndromes, not general clotting. So cerebral venous thrombosis or abdominal or splanchnic circulation thrombosis, and the heparin-induced thrombocytopenia. But anyway, now that we've got the access to Pfizer and Moderna for everybody, that shouldn't be much of an issue. So important that people know that the vaccine is completely free. So we certainly have, for people who don't have a Medicare card and generally as well don't have English as a first language, there can be some concerns, and we really want people to understand that that's actually got no relevance to whether you can be vaccinated. People do have to bring photo ID, and we do realise that there are a couple of bits of our system for booking which kind of are a little confusing if you don't have a Medicare card, and we are working on that. Because at the moment, for example, when you're recalled for a second vaccine, it says bring your Medicare card with you, which is very good if you have one, but if you don't, not so. So we are working on tweaking that so that people realise that they can still come for the second shot. And can people switch? So this is obviously something that we get advice from ATAGI. At the moment, ATAGI is saying no, but they are looking at this. This is something that they will watch in a close way. So obviously it is happening overseas, but what ATAGI particularly is looking for with this is safety. I think everybody thinks it will be an effective strategy, but it could be that it's more reactogenic, switching to a different vaccine, but still the jury's out on that. But of course, if you're somebody who's had a first dose of one of the vaccines and you're now contraindicated from a second, that would be an example when you would allow the mixing. The other scenario is, for example, if you had and this is going to not happen too often anymore, but if you had AstraZeneca pre-pregnancy, when people are pregnant, while both vaccines can be given, the preferred vaccine is the Pfizer. And so most pregnant people will be offered the Pfizer even if they've had AstraZeneca before. But like I said, that's probably diminishing and hardly anyone will fit that category. Okay. So now I'll just go through the questions we get and how we've been pulling stuff together to respond to it. Are there any other, should we stop for it, pause for any questions?
Been any on the chat.
Okay. So, what's in the COVID vaccine? So this question is a variant on, I think there's a tracking device in there or a microchip or something of that nature. I have to say I did research where that may have come from, and there is actually, as with all of these things, there's usually something that allows people to imagine that it's scientific. Apparently there are some kinds of syringes that have microchips in them, which I had never heard of, and I thought, wow, that's a really unusual thing. It's obviously for a different purpose than for vaccination. And so that's, I think, where people have grabbed that concept and mixed it with the vaccine and said we are inserting a microchip. But sometimes it's actually helpful to go to the source of the theory. So then we can easily and directly work with that. So anyway, the vaccine just does contain a protein component or a genetic code for the protein, small amount of fat. With the mRNA, it basically allows it to go through the cell wall. An adjuvant, a small amount of preservative, and sterile or saline. And that's it. And we do actually go through that for those types of questions. How were they developed so quickly? This one is an extremely common question. So, I mean, there's quite a few factors that come into play. One is significant amounts of funding, so no one had to apply for grants and what have you. There was collaboration across universities, which is highly unusual. There'd already been study of other coronaviruses, and the mRNA technology had actually been worked on for 10 years. And so while it looked like it was new, in fact, it wasn't new. The large number of people who volunteered for the trials meant that the trials had their recruitment really quickly, which, as you would know, normally takes them 18 months to recruit to a vaccine trial. And also, there's a lot of virus around, so it was also easy to see when there was a difference between placebo and the vaccine group, which, for example, with meningococcus group, you can go for years to pick up the difference between the two groups. The other thing that happened is that for many of them, the phase 1 trial, so that's that small safety trial, safety and basic effectiveness of the vaccine, ran directly into phase 2, which was a larger scale. And as soon as there was enough data to suggest that it was effective and safe, phase 3 ran as well. So if you like, there was in fact in parallel processes that happened. But I guess the really important thing for people who are worried about this is that there were no shortcuts. There was just less time in administration and kind of wastage. But I think really with the mRNAs, because they were ready to go, that really just meant that it was an entirely different proposition for them. So another question is, can I get COVID-19? So it is, I think, useful to talk to people through live attenuated vaccines and how this is not. Long-term side effects. Now, this is one of the things I have heard actually more and more is a concern that people will die 2 years after vaccination. That seems to be something that has gone around, and it's interesting because that 2-year thing is what you repeatedly hear. So clearly there's something driving that misinformation. So this is really just general, but it goes to that point that no vaccines have any side effects that go beyond 3 months. And so I guess we wouldn't expect to see that. There's also, of course, been the process of monitoring for side effects of the vaccines that we've got. And we haven't detected any late or delayed side effects. But one of the things that we do talk to people about is that the system of active surveillance of vaccine side effects is in place, and it's not just in place for COVID, but that's just normal business. That these are the normal systems we have that keep our health system safe and effective, and we're using those exact same systems for this as we normally would. And so if there were long-term side effects, we would be picking them up, which we're not. So this one, do COVID-19 vaccines impact fertility? It's probably the most common and most difficult one. So, I mean, for some people, just saying there's no evidence that there's impact on fertility is enough, but that's not the case for everybody. So there has actually been a study that was, I just saw New England Journal that that was for pregnant people rather. This one here has a few studies that were conducted in IVF type clinics, 4 for women, 2 for men, where they basically were able to scrutinise the eggs, the sperm, and also the embryos, and to look for whether a person was actually fertile or not. But there's basically what they found was no effect of the mRNA vaccines on fertility in these very small trials. One of the underlying myths here is that people believe that the mRNA will interfere with DNA and that will have an ongoing effect on fertility. And what we talk about with that is really go back to how the mRNA virus works, that it goes into the cell, but it does not go into the nucleus where the DNA resides. And once the protein is created, the mRNA is destroyed by the cell. Cannot leave the cell again and go into the bloodstream and go into a different cell. So it basically remains local where it's injected. So that's one thing that people talk about. Another thing that people talk about is in common protein between a placental protein called, I can't remember, syncytin 1 pronunciation, but a placental protein and the spike protein. So again, it has a microgram in it that people have picked up, and that is there are some base pair equivalents between this protein, the placental protein, and the spike protein. But as everybody knows, when you create an antibody to a protein, it is a mirror image. It locks in and it identifies precisely the spike protein, not a few base pairs. And so our antibody response is to the spike protein, not to a couple of base pairs. And so it basically is impossible for any antibodies to attack a placental protein. For people who are more health literate, I mean, it's kind of also biologically implausible that we would ever mount an immune response against our own placental proteins, because we would not exist as a species. So I think depends on the person you're talking to as to kind of how far you go with that explanation. But I think it is important that people understand that that's where people are getting it from. But I think explaining that an antibody to a protein is a mirror of the protein. So it needs to lock in, otherwise it doesn't work.
I was going to add to the fertility. I know there's a lot of talk around the accumulation of the vaccine in the ovaries and the fat in the ovaries. I don't know if you've had much in that way. So I get quite a lot of things emailed to me, and I was just checking. I couldn't remember what the paper was, but I was emailed a paper that was presented of a Japanese study that was looking at the accumulative effect of the vaccine within the ovaries, measured in a 48-hour period of time, and it was showing that there was a certain amount and noting this was just concentrating on the ovaries, and there was accumulation of the essentially of the vaccine in other organs of the body. But that paper was then used a lot to push that message then along, that it was potentially then to impact fertility because of that cumulative effect on the ovaries. And I've been asked in press conferences as well from female journalists around the impact on the ovaries and essentially the reserve, and is that a concern around the impact around the cumulative effect? So these are obviously very strong messages circulating still through around this, and I do really worry about this, the age group around it, particularly child, when people are considering are they going to be delaying it because of this sort of misconception around what we are seeing around the cumulative effect. That really that's just looking at something in particular and submitting something to a journal that then didn't progress, but then gets people talking in a social media space.
Yeah, interesting to know how they would have actually identified anything in the ovaries with ovary removal, because how else could you do it? I mean, we've obviously had lots of examples in the past where papers are written that later get retracted and that have nefarious motives.
Yes, and this is the same thing happened in this particular, but it's interesting how quickly things spread so easily on social media, and then suddenly got this whole discussion around ovarian fat and vaccine within that.
Yeah, interesting.
Yeah.
Okay, so COVID vaccines changing your DNA. We've really already talked about that one. Okay, so this is just really about people who are immunocompromised. The biggest message was really that people need to be vaccinated now. Severely immunocompromised people will be eligible for a booster. And also the timing is the matter for people who are on particularly drug-induced immunocompromise, such as cancer therapy. That's the same sort of thing. So COVID-19 vaccine in pregnancy, this is also something that we hear about a lot. It's really kind of on a continuum, I think, with the fertility one. This is one of our standard slides that talk to the complications of COVID, having 5 times higher risk of hospitalisation, 2 to 3 times higher risk of needing ICU, and 1.5 times higher risk of a preterm or special care nursery admission. And so I guess one of the things we're really keen that this group of people are vaccinated. And this is where, the New England Journal of Medicine paper published in June, basically reported on in the United States people who had been effectively inadvertently given the vaccine mRNA without realising they were pregnant. And so this is a series of 35,691 pregnant people. So they followed through these people for their side effect profile. It looked exactly the same as non-pregnant people. And at that time, there were 827 births, and the outcomes of the births for the mother and the baby were basically the same as usual. So it's probably the most rigorous and largest scale, but there are multiple other smaller scale from all over the world actually that look at safety in pregnancy, and it does look safe. And the TARGI's recommendation is that pregnant people should be vaccinated at any stage of the pregnancy, and in fact they're a priority group. But I do think that many healthcare workers have concerns like this from
I've heard it from my own GP peers.
Yeah. But I would also note that 10 years ago there was hesitancy about influenza vaccine in pregnancy too. And there's much less hesitancy now, both from healthcare workers and from pregnant people. And so there's probably something about that newness and extra fear.
And that's the main messaging that seems to be coming through with this current campaign as well, around trying to get the uptake in pregnancy now and using this particular information to try and drive that message. I've seen it in the comments coming through on social media around this, that particularly people are very concerned about how can you possibly tell around the time frame that you've had the vaccine around for, given the pregnancy duration of 9 months. How do you have enough data then to support this decision making? And it is exactly right. There are now really good studies to support the use, which is why we were a lot slower than other countries at moving towards this position as well.
Yeah, we were slower. We didn't start that way. And I guess the other thing is that now there are many tens of thousands of people, probably in the hundreds of thousands of pregnant people who've been vaccinated. So this is just rising pretty quickly. So safe for people who are breastfeeding. And the question of whether the vaccines contain animal products, no, they don't. And they also, for people with food allergy, they will be asked about general allergic reactions to things when they go to get vaccinated, and it just will mean an extra 15 minutes, so a half-hour observation, just to make sure that there isn't a bit of a slower allergic reaction. I should also say no fetal cells as well. That's one of the other concerns that some people have. And for the mRNA, there was no fetal cell or fetal cell derivative, the cell line that is often used, was not used in the production of the mRNAs. And I also understand that the Catholic Church have been clear that they approve the use of the COVID vaccines. So for some people, it's really important to be clear about the one vaccine has an effect, but it will wane relatively quickly. The second vaccine is to boost that immune response, and that people won't really be immune until 14 days after the second dose. This is probably quite important to articulate clearly for people, so that they understand, for example, that it does take some time. One of the things that we know some people are waiting for is an outbreak in the community where there's COVID around, and then that makes it worthwhile because there's something now that we're trying to avoid. But they should know that it's a minimum of 5 weeks from when you make that decision to be vaccinated, and that might be too late. So we've talked about this, and these are the kind of simple messages that we want people to hear. We also really want people to talk about the fact that once you've vaccinated, you still need to be tested. This is particularly important if you have people who have less health literacy, who may just think that vaccination is sufficient. And if you have, SA Health has got this translated into 35 languages. So if you want any of these at the website, we'll have them for you. So we've talked a little bit about the booster. We're still waiting to hear from ATAGI. My understanding is that they're deliberating further, and that we might hear by the end of October, possibly early November, about what could happen with boosters within Australia. But in the meantime, those severely immunocompromised people, once they're at the 6-month mark, can be offered a booster and should be. There's definitely good evidence that a booster is far more protective for people than just the 2. Okay, I'm going to take a pause there because that's all the fact stuff, and this is now talking about how we talk about it.
We do have a couple of questions. Going back to the part where you spoke about access to vaccine and needing ID or Medicare card,
Yeah.
Kylie's raised the really important question that the matter of ID can be an issue for at-risk homelessness, homeless people who've been released from prison and other vulnerable communities. And she's wanting to know what sort of support or process can be provided to enable this community to receive the vaccine.
Thank you. That's an excellent question. We, as part of our vaccine hesitancy work, we've actually now just pulled together a group of people who are advising us on people who've had, recent prison release or are on parole, or perhaps don't want anything to do with authorities. So we're working with the Justice colleagues and people like HAWS and Aboriginal Legal Rights Movement to basically give us advice. So we realise we need to be bespoke for the community. I think SA Health facilities SA Health vaccine buses are going to be the way forward because it means we can be a bit more flexible. But this is really about the recording on the Australian Immunisation Register. So whether we do it as alias, look, I actually don't know how we will deal with people who really want to remain anonymous. That is something that we're working through.
Thanks. There was also another question around, some people think that the swab, when they've been tested, is taking a sample of DNA as well as looking for the virus, and their DNA is kept on a database and may be used without their consent in the future. And was asking for advice on how we explain the swab testing process, which is relevant to this question of you still need to get a swab if you have. Do you want to?
This was a question last year. I remember this came through one of our webinars before, and I think we actually had to provide quite some senior advice through to various defence personnel because of the fact that when we swab defence people, because you are actually undertaking a sample of and a specimen, there is that potential then that you could run DNA analysis on it. So being really clear, we had a protocol put forward by SA Pathology, and it was signed and delivered that in fact there is no potential possibility to run any DNA sampling on what's been undertaken because there's a requirement to follow national guidelines and practices under accreditation. But it's an interesting point. So for instance, when we had US personnel in our hotel quarantine, we couldn't swab them and send their samples to SA Pathology. We had to send them to ClinPath because it couldn't be sent to a government laboratory because of the risk under requirements under US legislation that you couldn't send it to a government lab because of the potential that DNA could be ran on that particular specimen. So so it is a real thing. It's not just a people thinking that potentially, oh no, you can't do it, but we have very strict protocols in Australia under how laboratories are managed as part of their accreditation.
Yep.
And how it's stored, and then the essentially discarding of the specimen, destroying it.
Excellent.
And another question around boosters, and asking if we have any understanding whether it's likely that frontline health staff who were vaccinated in March will be prioritised for boosters. This is a question we all like an answer.
But I don't think. I think we have to wait for a target because they haven't actually advised that we proceed with boosting. I've certainly heard the two schools of thought. One of the schools of thought is that while there's evidence, obviously with Pfizer, that there's a reducing in antibodies over time, that maybe that doesn't actually make a huge difference to immune response because of the cell-mediated immunity part of it as well. And so I've heard one school of thought that says, really we need to see breakthrough infections and that those increase, and it's different from what it would be at the beginning or immediately after your second dose plus 2 weeks. I've definitely heard that. And so there's still a school of thought that could be in fact what's happening, that the real immunity is not measured by antibodies. And then the second school of thought is that, yes, but if we give a booster, we get much better protection. And there's the evidence from the big study in Israel which looks at that. And it certainly is the case that people boosted got much higher, I think it was 20-fold, in fact, protection. So we wait to hear.
We have a lot of discussions about this internally in the department around who's going to line up first for their.
Well, I've had AstraZeneca, so I'm just fine, thanks.
But I think we're very fortunate that we can look at a lot of the data as well from both interstate and overseas to look at what's happening with ICU admissions around fully vaccinated groups. And I think we're really interesting, particularly Singapore will be a really interesting country for us to look at around admissions and noting how good their healthcare system is so far at being managing COVID.
Yeah, so I think we need to see more.
I think it's also really important to differentiate, certainly the use of a third dose in people who are immunocompromised, and very much the language from ATAGI is around this is a third dose of essentially a primary course,
yes,
as opposed to a booster, because immunocompromised people probably haven't ever mounted an appropriate immune response to have good long-term immunity. So there's currently a guideline for a third dose. We're all hoping that we will get a booster at some stage.
Well, you mRNA people maybe. I'll be just fine. Okay, so I'll just move forward. So this vaccine hesitancy now, I did have another definition here actually before, but this has really just recently been published, that it refers to a motivational state of being conflicted about or opposed to getting vaccinated. It includes intentions and willingness. So there are a number of things that influence hesitancy, and we have actually been measuring this in South Australia basically all of this year. And in South Australia, our top 3 reasons for hesitancy are safety concerns, a lack of information about the vaccine and the rollout, and the other one is people who believe there's a low risk of disease, and if the disease is here, that they're not at high risk. They're our top 3. But other things that drive hesitancy is lack of trust. That might be lack of trust in government, in health services, or in science itself. And that perceived scientific uncertainty. So, for example, there are people who say, well, if we don't know how long immunity will last, why would I bother getting vaccinated? So these are the drivers that we're trying to work with. I just wanted to acknowledge Professor Julie Leask, who is the source of many of these slides. So I think I just need to say that out loud, even though it's written at the bottom. So this slide is to represent basically the distribution of us across hesitancy continuum from complete vaccine refusal to complete vaccine advocates. What we're really talking about here is just really this group, the hesitant group, not so much rejecting and certainly not activists. Our goal with the rejecting person, so this is probably up to our 7% of people, is to just to not alienate, to not other, so that we don't ruin our therapeutic relationship going forward. So I'll just keep going. Now, the flip side of what motivates people to vaccinate, some of them are opposites to the other, but not all. High perceived risk of developing the disease, confidence in effectiveness and safety, trust, but we also have a desire to protect vulnerable people that motivates many people. Positive role models or role modelling can motivate people to vaccinate, and that's one of the most critical factors that we are working with this project. Healthcare providers. If a person has a good relationship with their healthcare provider recommendation is the single most important reason for a person being vaccinated. Trust in government and health systems is important, and obviously convenience. So this is where for making sure that they're physically accessible. So our goals here are to empower. So we're trying to give the individual, we're talking to agency over the decision they're making. We are aiming to encourage their trust in us and the vaccine program, and also facilitating easy access to information. As I've said, healthcare workers are the most important influence. And I guess the other thing with that is equally, if a healthcare worker is uncertain about aspects of the vaccine, perhaps they've been vaccinated themselves, quite happy to, maybe their whole family vaccinated, quite happy to do that. But a question comes that makes a healthcare worker look uncertain because they're not sure of the answer. That kind of appearance of uncertainty, unfortunately, can be interpreted by the individual as, oh, look, see, they're worried about something. I'll just maintain my hesitancy position. So the kind of confidence is quite important. So the role of a healthcare worker is a positive recommendation to vaccinate and to vaccinate now. So there's something about the timeliness of it too. Having awareness and knowledge about the vaccine will help in really that confident delivery, which is really critical. And obviously, as usual, messages delivered in an honest, culturally appropriate and consistent way. So this is what we know works as a general strategy, and this is what we're working to at the state level. Basically, the strategies are multifaceted. We need to directly target under-vaccinated groups. So that means understanding precisely the group's motivations and also their barriers to vaccination. We need to increase vaccination knowledge and awareness, and that's not just at that kind of grand scale communications level, that's actually individual one-on-one conversations with people, which can take a lot of time actually. We're aiming to improve convenience and access, so that's about whatever the individual community wants. So we're working with communities who are happy for a transport to be organised to get them to a vaccination hub. Others want an actual vaccine bus brought to wherever their community event is, and others only want to do it with their GP. And so we're kind of working with whatever is the right thing for the individual community. One of our most important things is to engage influential leaders. In a way, healthcare workers represent influential leaders, but for some communities, it will be a non-healthcare worker who the community trusts. And if we can engage those individuals and help them to be able to have those conversations, that will actually be the thing that will make the difference for us. And the other thing is normalising. So there is a social norm that we need to create for some communities. It's clearly there actually for the general community, but for our under-vaccinated populations, this is a massive problem. I don't think I've actually got a slide here, but I should tell you that from our data collection, we have some key groups that are under-vaccinated and have high degrees of hesitancy, that being Aboriginal and Torres Strait Islander people. The vaccination uptake is half that of the general population at the moment. So we've got around 25% actually who've had 2 doses of vaccine. That's just as of today. We also have around 50% of our respondents, Aboriginal respondents in our survey, report that they are hesitant to be vaccinated. So this is obviously a very serious issue. There are also some called groups. So people from the African continent, people from the Middle East tend to be more hesitant than the general population. We also have more hesitancy in people with serious mental illness, particularly if there's additional psychological distress. People who are unemployed, and we have a very kind of big vaccination hole in the north of the city. And probably because of all the groups I've talked about, generally live in lower socioeconomic areas. So we do definitely have communities where it has not been normalised as yet. So we should always be transparent and honest when we're having these conversations. So the risk-based conversation has got to be clear about benefits and risks, the known and the unknown. Because of course we need to maintain trust. It's really important that we don't, gloss over the potential risks and also conflate what we don't know. Obviously, things should be conducted in a respectful manner, and we're trying to avoid conflict and using active listening as a technique. Now, for these conversations, framing messages in terms of gain tends to be more effective because the negative could reinforce a hesitant position. So, for example, avoiding saying, if you don't get vaccinated, you could die. You would instead say, if you get vaccinated, you're less likely to have to go to hospital. So it just is really that kind of simple shift. For many people, appealing to altruism is the way that we know will work, or protecting family or protecting community. Obviously, when we're having these conversations, we need to identify barriers, and if we're able to, we need to try and resolve them for people. And then there's the issues of misperceptions, which I'll talk a bit more about. So this is a framework for how to have the hesitancy conversation, and I'll go through each of these individually. So the first thing is to really, using an open style questioning, is to understand the concerns a person has. And so this is really about asking a person, what are the concerns they have, what are the issues, and we need to keep going until we've kind of exhausted them. So even though they might come up with one thing at the beginning, we need to just check, is there more? So there might be 4 or 5 things. What we shouldn't do is, what I know is a natural tendency for me, at least, is that when someone says something that we think, wow, I really don't agree with that, we need to resist trying to write them on the spot. Even if we just, it's something that is difficult for us to do. So, because what we're trying to do is to we want to understand the issues, and if we kind of stop people right at the front, we might never hear what is actually the real issue, and they haven't yet told us. So obviously understanding an individual's perspective helps us to understand what the hesitancy means to them, but also helps you to work out what potential motivations they might have to be vaccinated. So once we've asked, and we now know that we've discovered all 5 reasons why a person is hesitant, we should acknowledge the concerns of the individual. We want to validate them as a person, but we don't want to validate what they've said as correct if it's not, of course. So when we're talking to them as well, we can say at this point, so you've got these issues, can we start by talking about problem A? So we're kind of setting a bit of an agenda, but the sorts of things that we might want to say in terms of acknowledging concerns could be, it's understandable that you have some concerns. So that's really important kind of validation of the person. So once we've set our brief agenda, we now want to share what we know so far about whatever the issue is that we've decided together that we will talk about. So this is where we're going to talk to the sort of stuff I said in the first half of the presentation. If we can find out a person's potential motivations to vaccinate, this is the time when really we need to use that information. And we can even just ask them point blank, what might be important to you about having a vaccine? Now, obviously, if we're speaking to someone who's anti-vaccination, we won't have gone this far. We will have identified that early. We would have backed out politely and made sure we don't marginalise in that process. But this is for people who are really, really just wanting to know more. So, yes, so now we get to the point where we've talked about stuff and we really want to say these are the options we've got, and we might make a recommendation. So we could use, for example, so if I could summarise, your options are to not vaccinate now or to vaccinate now. Now, this statement deliberately ends on a positively framed vaccinate now message, because there's also evidence that there's a recency effect. So the last thing said is the thing that is in people's heads rather than the first thing said. So that's just a technique that can be used. Now, if a person gets to the end of this whole conversation and they still really don't want to be vaccinated, what we're trying to do here now is really not close the door. We're wanting to leave it open so that a person can come back to us. And we might say something like, if there's an outbreak in South Australia or you travel interstate, the risk from COVID-19 is increased. Could we revisit your decision then? So that's about allowing further conversations to happen down the track. So, misinformation is much more difficult. Sometimes if they are really strongly held beliefs, held with conviction, there really is no way to deal with that. I think it's important that people are given the opportunity to hear another point of view, but it might then be that that's the point at which you back out of the conversation because you can see that that's quite fixed. But I guess it's important as well to acknowledge that in times of uncertainty, people are more vulnerable to misinformation. So whereas with COVID-19, from a scientific perspective, we have known and a whole lot of unknown. We don't know what's happening next year or the year after. We can sit with that level of uncertainty, but not everybody can. And sometimes these narratives are lovely packagings that help a person understand what is otherwise chaotic, looks like a chaotic world. And so these narratives just really help people to kind of accept what's going on and to move forward. So it's easy to see how that can then be a firmly held belief because it helps people. So the other thing about misinformation is that sometimes it's really interesting and novel, and that can be more enticing than scientists who often talk in uncertainties. It is also the case that some people can get themselves caught in internet algorithms. That means the only messaging they get is the misinformation messaging, and it's not balanced. So one of the important things here is that direct efforts to counter misinformation can backfire. And so it is not recommended that people go head to head dealing with misinformation. So there are some tips if you get this far into a conversation. One of them is, for some people, explaining the ulterior motive behind the misinformation can help. So this is about that idea of trust. And so it's about kind of seeding distrust in where that information has come from. One of the other things we can do is repeat factual information, and that strengthens its efficacy. So that goes to that recency. And we want to, in balance, not repeat the misinformation or do it as little as possible. So we are saying more of the positive factual, less of the myth. The other really important thing to do is explain why the information is false, not just to say that it is false, so that we're clear about how we're thinking about it. And this is where that extra information, for example, about, what precisely is it about being concerned about fertility is the person concerned about? Because sounds like there's multiple threads that a person could be concerned about. Important to get to the one that's important to them and to discuss it. So this approach here is from UNICEF. They've created a guide, and I do have some links to this at the end of the presentation. But basically what they're saying is, so a person says something, we lead with the truth, state the facts clearly. So we're just stating what is true. We're not saying, no, you're wrong, it's this. Instead, we're just stating the facts. We oftentimes have to actually talk about the myth itself, but if we do so, we kind of use less emotive words and we kind of weaken its effect. We then should be talking about why we think it's not correct. And we need to go to the kind of details that we talked about earlier. And then we want to really end with more facts. So we're just trying to layer facts rather than no, if you like, for people. I do have this one pretty simple example, and of course this is not how a real conversation would go, but really just to give the sense. So there's no evidence that COVID vaccine causes infertility. Some people have said that it can affect both male and female infertility, believing it can change your DNA. The COVID vaccines we have don't affect our DNA. The genetic instructions that are in the vaccines are quickly destroyed and do not go into the nucleus where our DNA sits. There are ongoing studies monitoring the safety of vaccines all over the world to identify side effects. So, like I said, pretty simple example, but it's really just to demonstrate that we should try and stay positive. We should be talking at facts and talking about whys, and using our time to speak about facts rather than myth. So, in conclusion, sorry, that's a confusion really, isn't it? Motivational and practical issues will affect people taking up the vaccine. It is important to realise that hesitancy is relatively common, and so we shouldn't, I guess, be concerned or be reactive to it, because actually for some communities, half of people are hesitant. Obviously, good communication as usual is helpful, but the active listening and tailoring advice is critical. Keeping knowledge up to date, which I have to admit is actually very difficult, because there are new things happening all the time. With vaccination, we always want to be respectful, so that we're respecting a person's individual autonomy. We need to help people access them and approach the misinformation in a structured way. And I just wonder if I can share, I was in a mental health forum today, and one of the participants in the forum who leads a lived experience network did point out that for some people with a mental illness, they've had the experience of the health system of being required to take medication against their will. And so we definitely have hesitancy in people with serious mental illness, but she was really just kind of helping us to remember that people have this lived experience of being forced and not having autonomy over what they can take as a medication. And so we just need to be cognizant of that when we are having those conversations, that we are well and truly and squarely placing the autonomy in the individual's hands. I thought that was incredibly helpful, so I'm going to share. That's it.
Which then leads into mandatory vaccination as being problematic in this space.
I'll leave that to you, Emily.
Oh dear.
And we have had a couple of questions on that, so I'll let Emily address it.
Okay, go Emily.
So around healthcare worker vaccination.
Yeah.
I can't see your question, so apologies, but I'll give a quick. I mean, this is I think it's going to be really quite a really intense couple of weeks now moving forward around mandatory vaccination changes coming in, and the fact now that it was endorsed nationally to bring in mandatory vaccination across the healthcare workforce, including allied health and including in the community within general practice, and into a number of areas where previously there's been no real where the state has not previously stepped into this area, and neither has the Commonwealth in terms of mandating. We've had the no jab, no pay, and we have seen that there has been a process around exemptions and how people have been managed in that space and been able to really work together over a period of time. You know, they've had months to work through the system, and then it's assessed on a case-by-case basis around someone's individual circumstances, taking into account their mental health, their wellbeing in making those assessments for exemptions. We are now moving into this mandatory space, which is incredibly strict, the requirements to meet it, and noting that this will affect over 150,000 people here in the state. We expect, based on healthcare worker numbers, but not only that, it will impact individuals who go and provide care or services within a hospital or in a healthcare facility. So individuals who undertake NDIS work, for instance, and in the mental health space, when we have, you know, advocates who come in and are volunteering their time in a healthcare centre, this will also apply to them. Very tricky. So I'm really quite concerned about the impact this will have on our workforce. And I did see one question pop up in the very brief time I was looking at the screen here around what the percentage of people, as we expect, that would be refuse vaccination. I think we've had some interstate numbers. We don't have very clear data here, but around 8%.
Yeah, well, our hesitancy data says 7.
Yes, so that's the vicinity. So really, we are expecting a workforce impact coming in from November, which is obviously not very good timing if we do get cases here in the community. And a lot of work is currently being, well, a lot of consultation is occurring within different groups, particularly in the allied health space around this, because in South Australia we do have quite an expanded definition around who is incorporated as part of the legislation and the enterprise around who is in the allied health group, and includes groups such as music therapists, where typically we wouldn't have that as part of our regulated allied health requirements for mandatory where we would step into that space.
So beyond ARPRA.
Yeah, it's beyond ARPRA. So we'll see how this that there's a new direction that's being formulated and will be signed likely on Thursday. But it has taken a lot of work to work with different groups, and then it goes back to this: how do we then, you know, have this sort of shared space where we talk through all the hesitancy and develop the communication, the autonomy? This then completely flips that around, which I think will be very challenging for general practice in this area. And one of the changes as part of that direction, and we haven't really had an opportunity to talk to a lot of GPs about this, but is the exemption criteria has changed. How we had it for the aged care direction was that people could go to see their GP and have essentially a medical exemption that was then uploaded, provided into the air. But what we are now moving towards is a signed off endorsement following a target advice, so that there is no additional scope to expand into other areas. So it'll be an incredibly strict exemption process, and that was and then each application will be endorsed by the Chief Public Health Officer. So it's going to be an incredibly rigorous process, which will mean there'll be very little scope for exemptions. In some ways, it's a positive, I think, for the GPs who are really struggling in that space, then to how to then work through on different exemptions and what may be acceptable to patients. But I think it will be a really challenging few weeks. So Mel and I and Katina, we're all here to support, to see how we can make these changes work. But it absolutely will affect across all sectors, so in community and in the hospital system.
And there was a suggestion from Kylie in the chat, actually, to perhaps do some role play of how to have these conversations.
Yeah, so actually, you know what I should say that we are at the moment turning this into an online training package. So we should have it by the end of October. That's what we've been promised. It will contain role play. So it'll have the conversation going badly, but it will be clear about kind of which of these kind of tips it didn't do or did the opposite of, and then we'll flip it and do it better, and we'll kind of point out as we go, this was the positive affirmation, this was this. So we'll have 3 personas. One of them will be a healthcare worker, one of them will be a community person, and one will be a real advocate, kind of telling everyone what to do. So I do hope that will be helpful, because I agree. I think we need that that bit of live to help us. Once we have that, we really want to make that as broadly available. There's no limits, if you like. We would like that to be, that will in fact also go to the whole of public sector. And hopefully through the PHNs, we can get this information out to all of you and to anyone else, actually, local government, cross government.
That's fantastic.
There's been another question from Angela asking, or suggesting that although there is the Ask No Share decision tool, she hasn't seen an online COVID-19 vaccine decision tool similar to the NMRV tool on the NCIRS website. And maybe that would be something useful to help with these conversations.
Yeah.
And there was another question from Angela around why local council immunisation services have not been included in the COVID vaccine program as yet, given their experience as vaccine providers and have a lot of contact with the community and hard to reach groups.
I'm happy to make a comment on that. There was actually a lot of discussion with the LGAs around this, and it wasn't that we didn't want to partner with the LGAs, but they were really focused on the NIP and making sure that they could run the usual immunisation program that they were currently delivering for the community. So it wasn't we didn't strategically leave out the LGA and noting how important the council vaccination program is and moving forward into how we do incorporate this in as part of a 12-year-old vaccine program and other booster programs. We'll be working closely with the councils to make sure that they are really heavily involved in this space, but unfortunately there wasn't really a strong appetite in the council space to be part of this because of the fact that there was such a huge demand to get people vaccinated very quickly, and there was concerns around resources and ability to then deliver the usual vaccines within the council. And it's also an incredibly underfunded space, the council vaccine programs at this point in time, because it's been for very small numbers coming through. We know that general practice, we have the council programs and then different immunisation programs that are picked up through the hospital system as well. And then now we've got pharmacies coming on board as well with COVID vaccines and the flu vaccine in 12 and up age groups. But it's how do we sort of make sure that we have a system that's sustainable from a workforce point of view as well. But the councils will be really, really important. We had one council that was very interested and we have partnered with them, and they are now doing some in-reach services as well, outreach.
And I guess going forward, if we put ourselves forward 2 years, one would imagine that councils will pick this up as part of the school program.
Absolutely. Yes, so a lot of work happening in the high schools. I think there's a question about high schools that came up.
Yes.
Yeah. So there is work being done on that, I know, around rolling it out.
Yeah. So my understanding is that there's a number of sites that are being used, and at the moment that the teams are working with, and they to kind of work out how it works and just see what's effective, what's not effective. But that will expand over time.
And something we can learn as well from Victoria with their how they've been able to really make sure that they're vaccinating in family groups is having vaccine clinics in schools on the weekends have been really successful, and that's something we're really keen to mirror. So one of the requirements for the schools that have agreed to have pop-up type vaccine clinics is they must be open on a Saturday to enable families groups to come in, and we really want to make sure that you vaccinate the whole family rather than just saying, oh, this particular child's been vaccinated and other members of the family haven't had that same opportunity. So trying to make it as easy as possible for people to be able to seek vaccines, and just for short periods of time at certain sites. So up to a week at one particular location, and then coming back in the 3-week time frame if it's the Pfizer vaccine being utilised.
I personally had a question around the conversations around for people who are hesitant, and I noted that you made the point that it's often not useful to emphasise negative aspects, so that if you get COVID you'll die. I'm really interested in the idea that as we are all facing this idea of more COVID coming into our community, and that it is perhaps inevitable that we will all be exposed at some point. Do you think that is a useful part of a conversation with someone, that not necessarily saying you will die, but you will be exposed to this disease at some point?
Yes, I do think so. And we spent some hours today kind of talking through how this might work in the community, because one of the things that makes this more concrete for people is actually allowing them to see turning the abstract of COVID's coming or whatever to something concrete. So one of the things that, and it obviously depends on the literacy of the individual, how far you have to go with this, but we are developing some visuals that will help with Delta variant style transmission chains. And so particularly when we go into smaller communities, what we will aim to do is to, and this also helps with the testing, that, you know, generation 1, we've got 10 people now, 1 plus, or 8, we've got 9 people infected. And then the generation, I already can't times that out as to what that is. So part of that is also to say, over the space of 3 weeks in this community, if it comes in and people aren't vaccinated, this is what we will see. And so if you're in a regional community that, you know, can quickly amass to a large number of the population. So that's one of the things, and that's why we're also using that to talk about if person 1 got tested, we only have to do contact tracing on 1 person. Person 7, generation 7 gets tested, we've basically lost the outbreak because there's hundreds of people we've missed. So I think those kind of really concrete things are helpful for people. One of the other concrete things that we're trying to develop nice pictures for is basically segmenting the community in those kind of people, you know, pretend people way. What does the distribution look like in a massive COVID outbreak for unvaccinated people? What proportion of people aren't sick? What proportion of people have COVID? What proportion are hospitalised in ICU and die? And then literally mirror that. Vaccinated people, same thing. How many people are not infected? How many people who have COVID are not in hospital? So really making concrete for people the difference, because I think, you know, just when we just say, you know, COVID's going to come and it will all get exposed, for some people might be abstract. And so we're just trying to develop these communication support tools that we hope will help. One of the other things that we've heard is very helpful for people is hearing exactly what's going to happen to them in terms of quarantine and isolation if they are wrapped up in a COVID case going forward. So you might still say as a young person, well, I don't really care because I won't get sick and I don't have anyone I see that's older, I'm not going to, you know, whatever. There might be all those reasons. But for some people, if you live in a share house with 4 people, one of you gets COVID, eventually it'll be found, even if you don't get tested, it will be backtracked. But the contacts quarantine period starts after the infectious period ends. And so you can kind of map out for people that for sometimes that means like 5 or 6 weeks in isolation. And that can be enough for people. Oh, well, I don't really want that. So that really just goes to being very concrete about exactly what's going to happen when we're in the midst of a massive, because in the midst of a massive COVID outbreak, we won't be putting people in a medi hotel. We won't have enough places. We'll exhaust that pretty quickly. So I guess I think those sorts of things that make it real is what we need to do. But we are working on those, and when we have them, we most certainly can send them to people.
I think that just comes back to the whole narrative in general around the strategy moving forward, is that exactly what you said. I think people shouldn't understand the reality that they will be exposed to COVID at some point in time. And because we have done such a good job here at keeping COVID out and running an elimination strategy, it's then how do you then transition the mindset of the community from an elimination to a suppression strategy, but noting the fact that you'll have lots of cases in the community where you know, you will be exposed. It's that risk that you will be exposed, and how will that then impact you? And then going into that long COVID discussion as well, which I know many people are really keen to unpick further now that we've got a lot more information from overseas around long COVID syndrome.
Yeah, and I guess the other thing is, if we fast forward 5 years, we'll all be immune. It will either be from vaccination or infection.
And variants.
Yeah, and then the risk of variants.
I think that's it for the questions so far, unless anyone wanted to add anything to the chat.
No, nothing further.
Here we go. So Kathy's said the SA Health Infection Control Day had some excellent information on how healthcare workers have a role in nudging or antibiotic use, and that there is a similarity around hesitancy. So the more we nudge, the closer we get to.
And if we all nudge together, I think that's the other thing.
Isn't it?
It's a general nudging
Can you have voluntary consent?
in mandatory vaccination.
I mean, it's a difficult space around consent and how this fits under a requirement under the emergency management. You still need someone to undertake a proper consent process, and it still needs to be a voluntary consent process. How they are administered the vaccine under the particular circumstances, understanding what the risk and the side effects profiles are, and then the follow-up requirements as well. But noting that you then have a separate then. As healthcare professionals, we do have to ensure that we undertake consent in the usual process, noting that there is those requirements then for mandatory vaccination. It makes it complicated from a consent point of view, but they still remain two separate processes. Wonderful. Well, thank you so much, everyone, for your time, and a very big thank you to Katina for Katina has come into this space really with a real drive to do whatever she can to try and improve this space for the community here in South Australia, to decrease the hesitancy that we're currently seeing, and has put an enormous amount of work into delivering this training across to different groups, but particularly developing materials that can be used not only for vaccination but hesitancy, as we sort of discussed in other areas around testing and understanding COVID in general. So a very big thank you to Katina for giving up her evening tonight and for being with us here at the PHN, and a big thank you as well to Adelaide PHN and Crystal Miles for organising tonight. And we're just so grateful that we have the PHN support to be able to deliver these really important webinar updates, and of course as part of our COVID response as well. And thank you, Mel, wonderful GP liaison Mel, who has been monitoring the chat tonight. So thank you.
Thanks, everybody.
Thank you, everyone. There's just a quick comment around access to the video. We will ensure that the link to the video, the presentation tonight, is shared in our newsletter, which will go out on Friday. I'll also ensure to share it with everyone that was on the session this evening or registered for the session, and we'll share the link as well with SA Health and Wellbeing SA, and I'm sure between all of us with the link, you'll be able to find it somewhere, but we'll certainly share the link with you. If you need any support in your practice or don't get access to the link, please contact your APHN practice facilitator, who will be able to support you further with access to the link or further information around COVID vaccines. So thanks, everyone.
Can I just add one thing that I should have said? We particularly at the moment focusing on the north of Adelaide, which has, as I said, extreme amounts of hesitancy and low uptake. So if there are any practices in the north where you're keen to have extra support from Wellbeing SA, please do reach out to me, because we are running bespoke support for different general practices in the north.
Thanks.
And if anyone wants to get in touch with Katina, you can do that through the SA Health GP liaison email, and I can put everyone together, and I'll just type that email address in the chat.
Thank you.
Wonderful. Thanks, Mel.
No problem. Thanks, everyone.
Thank you.